right, we are live. I think we are live. Okay, hi guys. Hi Megan. Hi babe. Hey guys, it has been a very long time since I've done one of these, so excuse me if I'm not technologically sound anymore. But today is going to be a very exciting day. As many of you know, I'm going to have my reproductive endocrinologist, Dr. Marcus Rosencrantz, on to discuss all things IVF and all things infertility. So, very, very excited to have him on. He's a wealth of knowledge. He is going to kind of just do a tell all about his company and where he's come from and all the good stuff that he brings to the table. For a lot of you who've been following my journey for quite some time, you guys know that I've had 4 failed IUIs with the previous clinic, and I went to Dr. Rosencrantz and we did our first ever IVF cycle, and that led to a successful pregnancy, and now I am 28 weeks pregnant with our miracle baby. So I'm very, very honored and gracious and blessed to have him as part of my reproductive help team in trying to conceive. So without further ado, I'd love to have him on. I just saw him. So Dr. Rosencrantz could request. If not, I can add him. Give me 1 second. Let me see. Okay. Okay. I just sent the request. It should be coming through in just a second. There he is.
Hey, Crystal.
Hi, Dr. Rosencrantz. How are you? Happy Friday.
Happy Friday. I'm great. How are you today?
I'm well, thank you. Thank you so much for coming on. I know how busy you can be and how you are. So it means everything for me and my followers to have you on to kind of just chat about all things IVF, all things infertility. So thank you for doing that.
That's really nice of you to say. I appreciate that, but it's an honor to be here and to have been able to take care of you as well. So thank you.
Yeah, of course. So I know we're pressed on time. We have 30 minutes blocked out. So I want to be very respectful of that. We have so many questions that have come down the pipeline. But before we even dive in, we'll try to get through as many as we can for the day. I would love if you could just tell us a little bit about yourself, your practice, and all the good stuff that you have to offer.
Okay, be happy to. I did all of my training in San Diego at UCSD, and I graduated from my REI Infertility Fellowship in 2010. And my wife, who's also a physician, and I both took jobs up here in Orange County. So we moved up here and started to work, both of us at Kaiser in the OBGYN department. And I was at the Kaiser Irvine office up until 2019. It was about 2017, 2018. I got a little bit of a 7-year itch there, and felt like I wasn't able to take care of patients in the comprehensive way that I really wanted to. So I started to work on this dream of putting together Reproductive Health and Wellness Center, where we, have a more comprehensive approach with our patients, and where we take our time, and can see each patient and give them the time that they deserve. So it was 2019, got it all put together, left Kaiser, opened RHWC, and it's been a blast ever since.
Yeah, that's amazing. And congratulations on your new practice. Very well deserved. I know that a ton of my followers who've become friends have asked for your contact information, so that's been passed along through the channels. I'm sure you're, helping a lot of them now, which is fantastic. But without further ado, I know, again, we are very pressed on time, so I'm going to get through as many questions as we can. within the 30-minute block that we have, but if we can't get through everything, it's fine. We can possibly do a future one in the future or later down the line. And you have to excuse my Frenchies. It's playtime for them right now. But yeah, so I am going to start off with just how they've trickled in. The first question comes in asking, what is the best prenatal vitamin for somebody who's trying to conceive? And is there a difference?
Yeah, that's a tough one because there's so many different prenatals out in the marketplace, right? There's like a gazillion of them. So yeah, there's not really data on which one of these vitamin companies are going to be better than the rest. But I guess if I was thinking about it and you said, gosh, what pin me down to something, I'd probably say there's Nature Made. You can find that in a lot of stores, I think. Ritual is another brand that does a good job. Smarty Pants prenatal vitamins, I think, are at Costco. Another good one. I think at the end of the day, a multivitamin, with folic acid in it, is probably the most important thing. And it's also really important for patients to start that even before they get pregnant. So we want patients on a prenatal vitamin, 1 to 2 months even before they start trying. Perfect.
Thank you. What are your thoughts on relocating embryos out of state?
Yeah, usually I think that's fine. I mean, there is an inherent risk with transportation. When we do our transport of embryos, they are actually in liquid nitrogen instead of just the liquid nitrogen vapor. So they're actually in liquids. I think that makes me feel a little bit better about it. But there's companies that do this. This is what they do. They know that they're taking on the most precious things in the world to people, and they transport these kinds of tissues internationally without incident. So I feel safe about it, but it is a little bit of risk. Things can happen.
Right.
Things can happen. But overall, I'm fine with it, and we accept tissues from other places. People move, life changes, and these companies are great at what they do.
Absolutely. Okay, that's really good to know. Another question came in asking, do you have more successful boy or girl transfers?
I have no idea. We've never looked at the data that way, so I have to be honest, and I don't know.
Okay, fair enough.
I wouldn't suppose so, Crystal. I would think that it would be the same.
Okay. Very good. So this one's a little bit more in depth. She is asking, are 3 normal embryos enough to achieve more than 1 pregnancy after the age of 37?
So, so the question is 3 normal embryos trying to get 2 pregnancies? Mm-hmm. I guess I would need to know a little bit more about the grading, the morphology of the embryos, because that also plays a role in success rates. So I think that if you had 3 beautiful embryos that were normal and you're looking for 2 pregnancies, I think I could feel comfortable with that. But if the morphology was a little lower on some of them, then that would probably make me a little bit hesitant and a little bit more nervous about that. So I think the idea here is banking embryos, right? And trying to have some fertility in the future when you're at a younger age. And certainly always more is better, right? More is going to give you more chances.
Yes, agreed. Okay. This person's asking, I have both of my tubes blocked and I don't want to surgically remove them. What are my other options I have to unblock my tubes?
That's tough because there's not a lot of tubal surgery going on nowadays. So that's a really tough one. There are catheter treatments that patients can try, and that's done in interventional radiology, and they put these catheters through the tubes and try to see if they can't open them up that way. It depends a little bit also on where the blockage is. Is it closer to the uterus? Is it at the end of the fallopian tube? if it's closer to the uterus, that would probably be the best attempt, but it's not always successful, and sometimes it's successful and then they just close back down again. So that's problematic. If the blockage is at the end of the tube, you could try to have surgery to open that up, but success rates with that are really low also. So it's a really tough spot to be in. And normally those patients are going to look for IVF as their best treatment option. Yeah.
Okay. And here's a good one. What would you say the biggest difference is between a medical facility versus a boutique style clinic like yours?
Back to one last thing. If that patient had a tubal ligation and purposefully blocked their tubes, then there is a surgery to try and put those tubes back together. It's a pretty delicate surgery, but that's pretty reasonable actually. If there's enough tube left to do. So I don't know what other people consider. My definition for boutique is this, just that we're not, we don't rush people through here. We're always try to be as accessible as we can. We have a great, small, compact team where people are super high functioning. And so you get to see the same people all the time. And I think it's just really about that feeling of not being a number for patients.
Absolutely.
Right? Where we know them and we know their story. And I think patients can really feel that when they come in here, especially if they've been to other places. But for me, that's our definition.
Yeah. And that's perfect. And I can piggyback off that, because the clinic I went to for all of my IUIs, my 4 failed IUIs, was huge. It was a really big clinic. And I felt like, I hate to say it, but I felt like cattle call almost. Like I had a different doctor for every procedure, a different, technician. It was never consistent until like I went in for like actual procedures where I met my, RE for insemination for my IUIs. But your clinic has been phenomenal because it's just you and then Cindy and then obviously the other nurses that are extremely helpful. But it feels like family almost. And every time I came, it was like warm and fuzzy, and it was just exactly that. It was never rushed, and the process was like super fluid. So it's great.
That's really sweet of you to say, because that's really what we're going for. And I think patients feel like boutique means more expensive when actually that's not really the case, and that's not really our definition. It's really just being there for the patients, and that's me doing almost exclusively all of their ultrasounds, all of their visits. They get to see us, and the process is really so stressful for patients to go through all of this and their journey, and then come in for treatments that may or may not be successful. But to be able to see the same people, to have that consistency, I think is really one way that we try and help our patients, at least with the stress of this whole process.
Yeah. I mean, I'm listening to you, but I'm also reading through the comments, and you're getting so much love, by the way. I mean, so much love across the board.
Is that what those hearts are that are floating up on the screen?
It's that, but it's also their messages, just like Dr. R is the most amazing doctor, best doctor in Orange County. There's just too much, but it's an overflow of love and abundance of love to you. So I agree. I completely agree with everyone.
That's really sweet. Thanks, Crystal.
You're welcome. So back to more questions. Okay. This person is asking, she has 2 PGS tested normal embryos that both resulted in miscarriage. The blood tests she's already done are ERA, Emma, Alice, intralipids. What would be her next step?
So obviously, I think every patient has a different story. So I think if you were my physician, we would circle back together and really go through your case and your history. When I'm thinking about my patients, there's 3 buckets that I think of when we don't have success with a transfer. And so we think about the embryo, we think about the uterus, and we think about the patient also, right? And so embryo, unfortunately, there's not really any more testing you can do. We have grading, which is great. You have its euploidy, aneuploidy status. We have its chromosome status. We know it's normal, so that's great. But that's all we know. And I guess I'm hopeful that someday there'll be more telltales coming from the embryo itself that can help us with success prediction. In terms of the uterus, so when patients don't have success, I think it's worth going back and making sure that there's no lesions in the cavity. So no fibroids, no polyps, no scar tissue for any reason. Sometimes we might repeat a 𝐪𝑯𝘧𝘭𝘏𝑔, a study to look at the fallopian tubes to make sure there's not damage there that's causing issue. That's on top of the saline ultrasound. We usually would take a closer look at the uterine lining. So I like that ERA with the EMMA and the ALICE. So looking at the timing of when to do that transfer, because every woman might have a little bit of a different window of implantation. There's also the EMMA ALICE, which looks at infection, which I think is important. There's another company that's called Receptiva DX, and they look at inflammation within the lining. So those are all biopsies. So we take a little bit of tissue from the uterine lining and send those out. So those are the uterine tests. Maybe hysteroscopy instead of a saline sonogram, but some uterine cavity evaluation. And then we look at the patient, right? Any medical conditions, any history of endometriosis, are they being optimized in terms of any diabetes or sugar control or insulin resistance, any issues with their thyroid. We check vitamin D levels on all of our patients and blood counts. So those are just an idea of ways that we optimize the patient. And I think there's lots of intricacies in this, and it really just depends on the patient and their story and what they've had done. But you never seem to really run out of things that we can test for. I think there's always more things, but I think it needs to be done in a strategic and organized way. Yeah.
Yeah. That's the great part about science, is it's just there's like ever so many different testings, and it doesn't like run out. So it
doesn't seem so. We did great with you. We had one transfer, right?
Yeah.
One transfer. Yeah.
Yeah.
It is so devastating. It's heartbreaking for us as physicians and for my staff too. You know, we want all of our patients to succeed. If it was up to us, it would be 100%. It's just, unfortunately, it's not like that. But I always think that there's other things to look at, and I think it's really important to know the patient's story, because we adapt. It's unusual where we do the same thing, you know, time after time. So another thing I think to think about is there a different protocol that works for that patient? I mean, maybe we're doing an estrogen progesterone protocol to get their lining ready, but maybe they need a stimulated cycle, or maybe they need a natural cycle. So there's other protocols that you can work with as well.
Absolutely. Thank you for that. So next question is, what is the chance a day 7 embryo would take at transfer?
Well, again, it's going to depend. I think it's going to depend a bit on the grading. I think if the day 7 embryo has been tested and is chromosomally normal, I think pregnancy rates are going to be a lot lower than what you would expect for a day 5, day 6 normal embryo. So in those conditions, we say maybe 20-30%. If it's not chromosomally tested and we don't know, it's definitely going to be lower than that. And that's one of those things, right? So that's something else is going on with that embryo, right? So we know how it looks. It might look beautiful. We know it's chromosomes, but it's slow, right? And it took 7 days to get there, and that's makes it certainly more challenging to achieve a pregnancy with a transfer. So what else is going on with that embryo? What else can we test for? You know, hopefully someday in the near future.
Got it. Next question is, how long should I wait after giving birth to my IVF baby before trying for another transfer?
Oh, that's a great question. So this is what I tell my patients is we say 9 months for a vaginal delivery, and we ask them to have a year for a C-section. You know, it used to be it used to be a year for a vaginal delivery and 18 months for a C-section. And it really, that turned out to be kind of just made up numbers. We didn't really have any data to support that.
Wow.
So I think that there's an appropriate amount of time where your body just needs to recover, because you have this human being living inside of you who's sucking out all your minerals and all your vitamins out of your bones. Yeah. And you just need time to replete all of that. So I think 9 months, a little bit longer for a C-section just because of the surgery and the incision. But gosh, if you cut your skin, I mean, it heals pretty quickly, right? So I think a year is a more than enough time for a C-section, and that's what we tell our patients. We also here at our center, we don't let them be breastfeeding. So when they do start trying again, they have to be weaned, which can be challenging. Yeah.
Okay, thank you for that. It's good to know. Next one. Do you have any successful FET tips you could share?
I think it's we sort of addressed some of those things with that previous question, right? I think optimizing the patient and their health conditions, optimizing the uterus, and making sure that is in good condition. Stress management, because this whole process is so stressful. So finding ways to deal with that. I always tell patients not to eliminate stress. That shouldn't be the goal, because that's never going to be possible, right? We find goals and how do we best manage our stress during this time. And we know that stress isn't good for our fertility success rates also. Some people do acupuncture as another one of these ancillary things. You can do acupuncture before and after the transfer. We have acupuncturists come into our office and do that for patients, and I think that can be helpful. I think diet, eating a healthy diet. There's so many different diets you'll read about for fertility. There's the keto diet, the Mediterranean diet, on and on. I think at the end of the day, a healthy diet, preparing your body is a good idea. Prenatal vitamins, also. I think there was one more on the top of my head, but I can't. Maybe I'll come back to it. But anyways, there's lots of little things that the patient can do to help themselves with these transfers, and we try to go over that as best we can with patients, because it's a team effort, right? It's a team between us and the staff and the lab and the patient, right, who's part of the team. We're all trying to do our best, and we want our patients to do what they can as well.
Absolutely. With me, because I have PCOS and I'm insulin resistant, right when we did our initial intake call for IVF or consult, I looked into the Mediterranean diet, and that's what I did a few months leading up to our whole cycle. So I think it helped. It gave me more energy, that's for sure.
That's great. Yeah, I think it's just so those things that we don't really talk about so much, but we try to here, and that's that comprehensive approach is stress, and it's nutrition, and it's acupuncture, and it's healthy lifestyle choices. All of that contributes, and none of them are a miracle in and of themselves, right? But what are the small levers that we can pull? What is everything that we can do that's in our control to give ourselves the best chances?
Absolutely. Okay, so this question is asking, what would be the oldest maternal age you would recommend for an FET?
So as patients get older and they get into these advanced ages, the risks of pregnancy start to really increase, right? Pregnancy increases the blood volume a lot. Pregnancy is really hard on the heart, and complications, those risks that we think of during pregnancy, like preterm labor, like needing a C-section, like high blood pressure, like getting diabetes in pregnancy, those are all going to be markedly increased as women age. So I think a comfortable age, obviously the younger the better, but if we're looking at upper cutoffs, right, I think 50 is really an upper cutoff for me, where I really like patients to be under. our American Society of Reproductive Medicine, our Infertility Society, talks about patients up to 55. So I think that that's not out of the realm of conversation, but women who are older than that also need to have additional testing before they get pregnant, looking at their heart, making sure their mammograms are good, having their colonoscopy, being, just all the health maintenance stuff. But I think always younger is better. But I think 50 is a reasonable, more than reasonable time for me. ASRM says up to 55.
Awesome. Thank you. Okay, we're still good on time.
Somebody said something about all my acronyms. I saw that pass by, so I'm going to try and, if I say something that's initialized, you let me know, Crystal.
Okay. I will. All right. This one is asking, if I have frozen untested embryos, can I unfreeze them and then PGT test them in the future? But will their value go down if that's done?
Yeah, you can. You can do that. It's not ideal. You have to thaw the embryos, you're biopsying, and then you're refreezing. So it's a whole nother step, a whole nother trauma that the embryos had to go through. So I tell my patients that it's going to decrease your chances by around 10%. When you do that, but it is totally possible, and we do that after we have a conversation about it, obviously, with the patient, if that's what they still want us to do.
Perfect. Okay. Ways to decrease chances of genetically abnormal embryos. Are there any ways to do that?
Well, chromosome testing, so with pre-implantation genetic testing, we can do that and make sure that the embryo has the right number of chromosomes in the right places with 98% accuracy. So that's that PGT. There also is, there's also carrier screening. So there's these panels of now 250, even up to 500 genetic diseases that you can be tested for prior to going through an IVF cycle. And most people don't have a family history of these genetic diseases. And what we're talking about here are things like cystic fibrosis, sickle cell anemia, muscular dystrophy, those things that can be passed down. And even though you don't have a family history, it actually turns out that a significant percentage of patients will still test positive for something, which is not a problem in almost all of these conditions, unless your partner tests positive for the same thing. And when that happens, when you both test positive for the same genetic disease, then your embryo, your baby's at risk. And so we can test the embryos just like we test them for their chromosome numbers. We can actually screen the embryos for that specific genetic disease. So unfortunately, we can't screen the embryo for 250 genetic diseases, but we can screen the intended parents. And if there's something there, then that can be tested for within the embryos.
Perfect. This question is asking, after a transfer, is it best to stay in bed or can I go about my daily activities?
Great question. I don't think we have a great answer. So I think it really comes down to the comfort of your center. For our patients, we ask them to be on bed rest for 48 hours. There are some studies that show that that's the way to go. I haven't seen any studies that say longer than that. I mean, by then you really think the embryo should be implanting. So longer than that doesn't really make a lot of sense. I've seen studies that let patients get up and go about their business, that day, 10 minutes, 30 minutes after their embryo transfer. Makes me a little bit uncomfortable. So I don't think science has all the answers on that. I don't think we know. I do what I think works well for our patients and have them rest for a couple of days.
Perfect. Thank you. Last question, because I know we have to wrap soon. I'm trying to think of a good one. There's so many, so I'm trying to pick. Let me see. Okay. This one's kind of broad, but this one's saying, what are some questions to ask my doctor after our 7th tested normal embryo, 7th embryo ended in miscarriage?
Seven. Can you read the question? Read it one more
Sorry.
time.
Okay, so she's asking, what are some questions that I can ask my RE after our 7th tested normal embryos ended in miscarriages? So she's had 7 transfers and 7 miscarriages.
Yeah, maybe they transferred more than one at a time. So it could theoretically, it could be less than 7
Okay.
7 transfers. Yeah, I think it goes back to the things that I mentioned earlier, and trying to think about these different buckets, right? And going back and saying, okay, were my embryos, even though they were normal, were they good enough? What was my expectation here? Looking at the uterus again and making sure that everything is okay there, even with those tests that we do for infertility, like the ERA, that endometrial receptivity assay, or the EMMA and the ALICE. I don't know what those are, not abbreviations. That one, the Receptiva, looking at the fallopian tubes, making sure there's no infection, inflammation, and then looking at the patient as well. I often get asked this is so hard. It's so hard for patients. We do typically have some treatments that we do for patients with recurrent miscarriage. So when they're out there, they've tried so many times. There are some things that you can do. So we do a immune suppression protocol, where we can use prednisone, Claritin, Pepcid to try and suppress that potential immune system. There's blood clotting studies, and we do some blood thinners, either Lovenox or heparin on top of our baby aspirin. Sometimes for any sugar issues, we would add metformin. There's intralipids that can help with the immune system. There's 𝐰𝐤𝐭𝐡, which is intravenous immunoglobulins, which we're not quite sure how they work, but also immune system stuff. So there are other things that we can add on to that cocktail to see if you have better chances of success. When we get really out there and we just don't know, there are reproductive immunologists. They're so few and far between. And right now, I don't do all that immune testing on patients because we just really don't know what to do with the answer.
Right.
And so for our infertility patients, or for our miscarriage patients, but they are out there. And I do think when you get to the end of the line of things that you've tried, I think that maybe seeing one of those reproductive immunologists and seeing if they have something to add to your story, I think is worth it. But I'm so sorry for anybody who has to go through all of that.
Yeah, it's heavy.
And I would say keep the faith. Keep the faith as best you can. There are studies that show that women who have had 6 miscarriages in a row, not IVF, but 6 miscarriages, just pregnancies on their own, 50% of them, if they continued to try, went on and had babies. So there should always be hope there. And I'm sure there's lots of other things to think about. We just have to see that patient in more specifics, because there's always donor, there's always gestational carrier. There's other things, but I wish that patients and all of you who have come to join us the best in your journey.
Thank you. Thank you, Dr. Rosencrantz. Again, it's always a pleasure. I mean, every time we talk to you, pick up the phone, get on any type of communication with you, it feels like I'm talking to family. So I don't mean to be informal or anything, but you've just been hands down one of the best reproductive endocrinologists I have been blessed to know. Your whole team is amazing. I will be a huge advocate for you guys always, because of you, 5 long years of our journey has finally turned into our miracle, and she will be here in the next few weeks. So
when's baby Chavez due?
So my OB is saying anywhere from 37 weeks to 38, 39 weeks.
Okay.
Which is literally what? Like 8 weeks, 9 weeks away. So fast.
Life will never be the same.
I know. I'm ready. We're ready for it.
Yeah. We're so grateful. We're so grateful for you. Thank you for putting this together and for being such an advocate for us. We really appreciate it.
Of course.
We're
no
grateful
problem.
for you.
So for anybody looking for a great RE in the Orange County area, reproductive health and wellness, I will plug all of their handles up top. This is Dr. Marcus Rosencrantz, the best RE. Maybe it's biased, but in all of SoCal. I'm going to save this live for anybody who missed bits and pieces of it. And just thank you again, Dr. Rosencrantz, for everything you do.
You're awesome. Thank you.
Bye, everyone. Thanks for tuning in.
Bye, Crystal. Bye, everyone.
Bye.